Kwe Unusakut. Good afternoon. Bonjour. I want to start by acknowledging that I'm speaking to you from the traditional territory of the Algonquin people. And I want to thank, in particular, those who shared their stories and approaches today over the last 2 days, in fact, on a difficult topic of anti-Indigenous racism in the healthcare system. Systemic racism resulting from Canada's colonial history remains embedded in our country's healthcare systems and continues to have catastrophic effects on First Nations, Inuit, and Métis communities. For too many, this is the systemic racism and discrimination in our institutions, and especially when seeking healthcare, is a lived daily experience. The fact that systemic racism among Indigenous peoples in Canada has become normalized is not acceptable, and action is long overdue. Without significant change, Indigenous peoples will continue to face harmful and persistent inequities in their health and social outcomes. Alors que les gouvernements, les dirigeants et les partenaires du système de santé se sont réunis ces 2 derniers jours, nous avons l'occasion de retenir l'attention des gens et de discuter de ce qui est un problème de société et une atteinte aux droits de la personne et aux valeurs canadiennes fondamentales, le racisme anti-autochtone dans les soins de santé. Ce que Joyce Echaquan a vécu n'était pas un incident isolé. Bien que de nombreux Canadiens aient exprimé leur indignation et leur incrédulité, la plupart des peuples autochtones n'ont pas été surpris car ils sont eux-mêmes été victimes ou témoins de cas graves de racisme dans le milieu de la santé. Le décès tragique de Joyce nous conduit à honorer son héritage à travers le principe de Joyce. Comme le souligne le Conseil Atikamekw de Manoine et le Conseil de la Nation Atikamekw, le principe de Joyce identifie les mesures nécessaires à tous les niveaux du système de santé, y compris par les gouvernements fédéraux et provinciaux et territoriaux pour lutter contre le racisme anti-autochtone dans les soins de santé. Reconnaissant leur leadership, le gouvernement du Canada versera 2 millions de dollars à la nation Atikamekw et à la Première Nation de Manoine pour faire avancer leur plaidoyer en faveur de la mise en œuvre du principe de Joyce. Nous devons aller de l'avant de manière concrète avec un engagement collectif pour changer nos façons de faire. Nous devons mettre en œuvre les changements nécessaires pour éliminer toutes les formes de racisme dans nos systèmes de soins de santé. The 2020 speech from the throne pledged to address systemic racism and committed to do so in a way informed by the lived experiences of racialized communities, including Indigenous peoples. My recent mandate letter committed to also continuing the important work to address anti-Indigenous racism in the healthcare system. And most recently, the fall economic statement proposed an investment of $15.6 million over 2 years to support the co-development of distinctions-based health legislation with First Nations, Inuit, and Métis partners. Until today, alongside representatives from organizations representing First Nations, Inuit, and the Métis Nation, I was pleased to announce the launch of the process to support the co-development of Indigenous health legislation. And I'm very much looking forward to working in partnership with rights holders, including treaty rights holders. This important initiative will advance efforts to transform healthcare delivery in Indigenous communities by ensuring Indigenous control over the development and delivery of healthcare services, and it will be informed by the work we do here. The federal government will also continue to supporting Indigenous people's representation in the healthcare field, and targeted anti-racism training and skills development will work collaboratively with Indigenous partners to develop and share tools and resources to increase knowledge of Indigenous practices and ways of being. We'll also continue to examine how we support healthcare systems to ensure we're working collaboratively to strengthen patient safety. The reports have been done on these issues, including the National Inquiry into the Missing and Murdered Indigenous Women and Girls, the Truth and Reconciliation Commission in Plain Sight's report most recently, and the Commission Vient report. They will all be used to inform discussions and plans of action. Significantly, as representatives of the federal government, we will continue to hold roundtables in large forums like this one to continue the dialogue, to monitor progress across actions, and to share information on best practices, necessary steps, and key accomplishments. Systemic racism is a problem that is national in scope. There's no vaccine against it. We remain fully committed to continuing the fight to remove the obstacles to equitable, culturally safe, community-led, community-driven, and distinctions-based approaches to healthcare. Miigwech, Nakumik, merci, Marcy Cho. Thank you.
Well, thank you very much to my colleagues and also to everyone who participated in this very important forum. Obviously, people participated with a high degree of vulnerability, honesty, transparency, integrity. And it was really, I think, moving to hear people's experiences, personal experiences, and professional experiences, both as practitioners and as individuals interacting with healthcare systems across all levels of government. And I will say a big thank you to the provinces and territories that were able to participate, and that's either sent ministers or deputy ministers. It's so important that we have political leadership as well as institutional leadership hearing these stories. And I think, one of the things I heard over and over, and certainly I will say that I share this frustration, is that we've talked about this issue for a very long time, really in community and at all levels of government. And there are hundreds of reports on ending systemic racism in healthcare, on improving outcomes for patients that are racialized, in particular Indigenous people. And, I think one thing that I heard clearly from all participants was this is the time to act. I will say that there was a complete acknowledgement, I think, by all participants that what we're doing is not working for Indigenous people. That we continue to have incidents like the incident that Joyce Echaquan just happened to capture on film before she died. This is not an uncommon experience actually for Indigenous people. It's common, it's regular, and it not only creates unequal levels of care, it creates actually barriers to care. Prior to politics, I spent many years working in community, and most recently before being elected, amongst Indigenous people that were experiencing homelessness. And I can tell you that one of the more frightening places for people to interact that were Indigenous, that were living in poverty, that often were living with a variety of different medical issues, was the healthcare system. And so this was not shocking to me as someone who's worked in community before, but I will say it's saddening that it continues, and it continues without abatement. From my perspective, what has to happen is that there has to be a transformation of power. And we talk about oftentimes laying on modules onto what exists, and I think some of the most powerful comments that I heard was the need for transformation from within, and that it isn't about teaching through a series of courses, cultural competence or cultural sensitivity or cultural safety. And there are a variety of different kinds of courses and modules that are applied in this context, but that many of the participants felt really came short of actually truly sharing knowledge and power. And so today I'm very excited to announce that the federal government is investing $4 million in a national consortium for Indigenous medical education. This consortium is led by Indigenous physicians in partnership with the Association of Faculties of Medicine of Canada, the Indigenous Physicians Association of Canada, the College of Family Physicians of Canada, the Medical Council of Canada, and the Royal College of Physicians and Surgeons of Canada. And the consortium will provide that leadership and implement Indigenous-led projects with the goal to reform and update the education of physicians to contribute to ensure Indigenous peoples have access to care that is indeed culturally safe and free from discrimination. So there is action happening. There are leaders in communities and in the Indigenous communities that are taking up the mantle of change and have the opportunity with the support of the federal government to actually lead that change from within. So thank you very much for, again, having us today. And I will say that I thank all the participants who, again, so freely shared their experiences in the spirit and the hope that this time there will be transformational change.
Thank you, Marc and Patty. And I'm speaking to you from my home in Toronto on the traditional territory of the Mississaugas, the Credit, where we honor all the Indigenous peoples who paddled these waters and whose moccasins walked these lands. Merci à tous ceux qui ont participé aux 2 derniers jours. Nous sommes tous reconnaissants envers Carl Dubé, le veuve de Joyce Echaquan, pour s'être joint à nous au cours de ces discussions, pour ses mots et pour avoir défendu le principe de Joyce afin que sa mort puisse amener un véritable changement. I think that the words of, and I wish all Canadians could have listen to really the inspiring words. And I think the wise and inspiring Carol Hopkins made it clear that our first responsibility is to ensure a future for First Nations, Inuit, and Métis, and ensure a future of hope. Yesterday, the elder Edmund Sakane reminded us that listening is the first sign of love. And I think that in our October meeting, we listened to the truths of the providers and the patients and the learners. And as well as it's important for us all to listen, because when you hear the stories, you only then can truly understand how our systems are making Indigenous people feel, how the health outcomes are unacceptable, and how bad experiences make Indigenous patients reluctant to access timely care. So these past 2 days focused on the solutions, on the concrete actions, as was asked, what is the moccasin path? So Dr. Karen Hill reminded, just as Patty has said, that tinkering around the outsides is not going to work. She reminded us we have to rethink the whole thing. The years of all the same words, and Joyce is dead at the hands of our system. It's not working. So she's advised it's time to get out of the box and reminded that the system is not broken. It was built this way. The colonial views of knowing best are not working. And it's powerful to know that we have to support the building of Indigenous health systems together on the path to self-determination, where their knowledge keepers and healers will be a part of improving primary care and public health, as grandmother Catherine Whitecloud reminded us about the social determinants of health, the role in prevention, and thinking 7 generations out. So I think we know, and it was clear, that we need more Indigenous health human resources and professionals. That means more nurses, nurse practitioners, midwives, and doctors. But we also need that to make sure that the secondary and tertiary systems are safe spaces for First Nations, Inuit, and Métis. The points of care have to have zero tolerance for racism. So Dr. Lisa Richardson really has been clear that we have to do more on the education, but we have to have the data, and we have to have real structures of accountability and governance. So this afternoon, we also heard about the need to recognize the importance of distinctions-based First Nations, Inuit, and Métis, but also the intersectionality of the two-spirit and gender diverse, the persons with disabilities, and the strong voices of the youth, who also want to make sure that the knowledge keepers and their elders have a role to play in a new system. And that Dr. Marlon Cook, the first Indigenous physician, was very clear how walking in both worlds, the role of the knowledge keepers and Indigenous governance is going to be so important. Dr. Margaret Greenwood from the National Collaborating Center on Indigenous Health asked us yesterday afternoon, what would the system look like? The vision of First Nations, Inuit, Métis health. And I'm really pleased that the National Collaborating Center on Indigenous Health will now house the repository of the wise practices in cultural humility and cultural safety. So I think we're all very grateful for the government's, but also the colleges and the accreditation bodies for the work that they have done to begin to eradicate racism, in that they also have levers and powers to actually deal with zero tolerance. So, as you know, the TRC Call to Action 24 asks for the education of professionals, particularly nurses and doctors, the National Inquiry into Missing and Murdered Indigenous Women and Girls, and the ongoing development of the National Action Plan, including our federal component, is very much part of this journey. And as we heard from Mary Ellen Turpel-Lafond yesterday, that as we implement UNDRIP, that action plan really has to focus on Article 24, which states Indigenous individuals have an equal right to the enjoyment of the highest attainable standard of physical and mental health. States shall take the necessary steps with a view to achieving progressively the full realization of this right. So we agree with Richard Jock, who said we need creative disruption. And I personally thank Dr. Makokis for bringing together such an inspiring group of colleagues grounded in their language and culture, who since March have shared every Thursday night the experience of their patients, themselves, and their relatives struggling in the medical education systems as well. So we're grateful for the candor and courage, the vision and values, and I think this evening we remember Brian Sinclair, we remember Atikamekw, we remember Joyce Echaquan, and we are committed to working together to stop these tragedies. Miigwech, Marcy, Nakamik.
Thank you, ministers. Nous allons maintenant répondre aux questions des journalistes. Une question de suivi. We'll now take questions from journalists. One question, and one follow-up. Operator, over to you. Thanks.
Thank you. Merci. Please press star 1 at this time if you have a question. S'il vous plaît, appuyez sur étoile 1 maintenant pour poser une question. And the first question, la première question, est de Christy Kirkup from the Globe and Mail. Please go ahead. La parole est à vous.
Hi, good evening. Thanks, ministers, for taking the questions. I just wanted to start off by asking what provinces were represented in the discussion. There was a reference to some provinces. So what provinces and territories participated in the discussion that happened over the last 2 days?
Kirsty, I can, unless Minister Bennett or Minister Hajdu has a more complete list. The list I have, first of all, Kirsty, that over the last 2 days, there's been about 500 or so participants that have fluctuated from high mid 400s to 500. Very many participants from all walks of life, which is really, really encouraging. In terms of representation from the provincial and territorial governments, all levels were represented to various degrees, and that we can confirm with the list. There were speakers on the last day that included all provinces, with the exception of Alberta and Newfoundland. Minister Dix from British Columbia took some time to offer some words, very poignant ones about point of care. Minister Yann Lafrenière from Quebec took the opportunity to speak about the work that he has pledged to do in Quebec to weed out racism in the healthcare system. From the Yukon, the Honourable Pauline Frost took part. And Northwest Territories, the Honourable Julie Green. From Nunavut, the Honourable Lauren Kusugak. And from Prince Edward Island, the Honourable James Hailward, I believe. And if I've missed out anyone of any elected officials, perhaps the Parliamentary Secretary from Ontario, Parliamentary Assistant to the Minister of Health, apologies, so not elected officials, but members of the civil service. I suspect we can provide you with a list.
Thank you very much. And sorry for the quiz nature of that question, but the reason I'm asking, of course, about the provinces and territories is I'm just trying to get a measure of how committed do the provinces and territories seem in terms of their role in ensuring that systemic racism is not playing out within healthcare systems that fall under the purview of provincial governments.
Well, knowing the number of jurisdictions that we have, it does vary. Clearly, British Columbia, that has been really at the forefront in tackling, in walking together with Indigenous peoples along the path of reconciliation, was present through, and the words of Adrian Dix certainly testified to that. I think all the provinces are in good faith in wanting to tackle racism and its effects on Indigenous peoples. We do need increased commitments in a jurisdiction that is primarily provincial, but that's not something that was new to this conference. I think the work that we've all identified by listening to the people that have actually experienced it. I mean, look, you're talking to a person who has never experienced any of the issues that were highlighted over the last 2 days. That is probably the case for a number of the provincial partners that were listening. So this was an opportunity to get that feedback and to say and to work with Indigenous peoples to get their feedback. They all know that we can all sit there and make lofty statements, but they will want action in the long term, in the medium term, and in the short term. And I think that's what we've pledged to our territorial and provincial partners to frankly hold each other to account. The reports are there. I've named them. People have read them. The specific clauses that Minister Bennett referred to in the United Nations Declaration of the Rights of Indigenous Peoples are there. Indigenous peoples are looking for us to be accountable and to apply them. And in the cases of their medicines, allow them the space to practice. The difficulty is when you work on the intersection between those practices and to treat them on an equal basis, which we haven't done up to now. I'm going on a longer point than you asked, Kirsty, as I tend to do, but there is an eagerness. I certainly don't exclude trepidation. I think we're all out of our comfort zone. We all know the impact that this is having on Indigenous peoples. There's reports out there to prove it, but there's a willingness to do it, and that's what I think gives me hope. I don't know, Carolyn or Patty, whether you want to add more on that.
Listen, I think I'll just add. I think. Oh, sorry. Do you want me to go first, Carolyn? I'll just continue. So listen, it's a great question, and it's one that I think the participants ask themselves. I mean, there is a difference between saying the right words and then doing the hard work of changing systems, like I mentioned in my opening remarks, that often require more than tweaking on the edges. And I can just tell you, as someone who, as I mentioned, worked in community, that the idea that we can somehow get to this with cultural safety training or cultural sensitivity training without a consistent and sustained effort at organizational levels to have increased Indigenous voices leading at all levels of the organization, a focused effort to employ Indigenous people in healthcare settings, a variety of different healthcare settings, changes in curriculum like the funding that I announced today that allows for more comprehensive integration of Indigenous principles in healthcare and in healing. I think, the fact that people were there today is a good sign. It's the next steps that matter, and what matters is that desire, and I do believe that everyone does have desire to have a system that's more inclusive, gets translated into tangible action. And I can tell you by watching the work of organizations in my own community, it is hard, it is sustained, and it needs a sustained commitment at the most senior levels of leadership.
Yes, I think that again that with Minister Dix, but also Mary Ellen Trepalafon's significant report that she shared yesterday, and the fact that next week will be her data report. I mean, they listened to over 9,000 people, and had, because of the disgusting revelation around the bingo game in mid last year, the fact that significant piece of work was done in 6 months, with really strong recommendations for everybody, I think speaks to taking that piece of work, and then hopefully there are some federal things that we are obviously working on, but also that other provinces and territories will look to be able to see what they could learn from that report and apply and tweak in their own jurisdiction.
Thanks,
and I
Christy.
think, I think, Christy, the other thing is that, as you heard, that the Royal College, the College of Family Practice, Accreditation Canada, all of the colleges of physicians and surgeons want to know how they can do better in including Indigenous peoples in the accreditation, but also in terms of the evaluation and consequences of bad behavior.
Thanks, Christy. Operator, next question.
Thank you. The next question, la prochaine question est de Brett Forrester from APTN National News. Please go ahead. Your line is open.
Hello, ministers. Based on these preliminary meetings, what might this distinctions-based Indigenous health legislation look like? Pardon me.
Hi, Brett. Perhaps, as you know, that in both throne speeches of this government, this has been mentioned. It's something that we knew we had to undertake. When I sat down with my team after being appointed Indigenous Services Minister a little over a year ago, we had extensive briefings on the process that we needed to follow in order to move forward on this, knowing the jealously guarded jurisdiction that we were, as well as the political minefield that it represented. If you look at any of the historical relations that we've had with provinces over healthcare, we know that this is a system that has failed Indigenous peoples in a country that we pride ourselves on having a first-class healthcare medical system that has failed and treated Indigenous peoples as second-class citizens. We know that it's been exacerbated by COVID, and so when I sat down, going back a year before COVID, a little over a year, knowing what the challenges that we had faced with C91 and C92 in terms of engagement and co-developing, I wanted my team to take as much time as possible to sit down and talk to treaty partners who often have different perspectives depending on their treaty areas, rights holders of various natures. So really have a long diligence process. The historical epidemic has increased the urgency of moving forward on this, knowing that the socio-determinants of health that have led to the outcomes that we've seen, particularly as tangibly measured in the South to Indigenous peoples that are 3.5 to 5 times at risk to the exposure of COVID. The challenges that we have with respect to housing, which is congregated living spaces, are a vector of transmission of the disease. These are all issues that have made this discussion very much something that is present of mind that we need to move a little quicker on. So forgive me if I don't have all the answers, particularly in knowing what I do over the last year, knowing that when it comes to the particular issue at hand that we've been discussing in systemic racism, I myself have never experienced it with respect to the healthcare system. So this will be a longer process. We've dedicated a good amount of financing in $15.5 million to start that engagement with rights holders to ensure that whatever we come up with reflects those voices, and there will be varying views on it. We heard squarely, and I've seen it throughout the pandemic, that issues of self-determination need to be at the core of the discussion. Federal leadership in the matters of weeding out racism and systemic racism need to be at the top of the discussion, but they need to be informed by those who have that as a lived experience on a daily basis, starting with the community and the Atikamekw Nation, the community of Manawan. It's why we've advanced financing to the community of Manawan to guide us along applying a principle that is focused on achieving real equality in the healthcare system with respect to Indigenous peoples. So it can take various forms, and I think these are sort of the things as politicians you want to kind of have control over things, and that's not helpful in this situation. We have to kind of let ourselves go and be open to criticism, open to change, open to feedback, open to solutions that we may not be comfortable with. People have asked me and asked Carolyn and asked Patty through what are you guys going to do in the short term? Well, we have a real opportunity right now to test what we have said we were going to do. And we've seen the proof of it through the deployment of the vaccines, treating Indigenous people on a priority basis, knowing what we know and our experience through the last 9 months. So you want an immediate action? Make sure the vaccines get deployed in a scientifically proven way to people that are marginalized by the healthcare system in a culturally appropriate way. We introduced healthcare legislation today, but it's been on throne speeches for 2 rounds now over the past year. It's something we've been given a tremendous amount of thought over. this was an occasion to launch it and launch the consultation process and discussion process.
Brett, do you have a follow-up?
Yes, just as a follow-up, Minister Miller, you mentioned Bills C-91 and C-92. What I'm wondering is if you're kind of using bills like C-92 kind of as a framework or a starting point. Is this something that you imagine will allow First Nations, Inuit, and Métis to assert their own jurisdiction over healthcare and the provision of healthcare at the end of the day?
Well, these will be informed by our conversations, Brett. What I do know, and it's measurable through the deployment of financial support and backing and assets that only the government of Canada can mobilize, such as the armed forces, such as surge capacity that we've been really massively procuring. Is that when those assets are put at the disposition, and when the financial control over these assets can be exercised by First Nations, by Indigenous peoples, by Inuit and Métis, the outcomes are better. They just are. It's measurable. It happens. And I think one of the real successes of the Indigenous Community Support Fund is the fact that it allows the implementation of pandemic plans that are tailored by the community itself, and the proof is there. So I won't presume the outcome of these discussions. We know, and when we heard it from ITK President Nathan Obed, self-determination is key. That is when it comes to the Inuit, there is a different set of considerations than we would have with First Nations. Everyone knows that, but we have to reflect that in our discussions. So that's my answer. I hope it answers it clearly.
Thanks, Brett. Operator, next question, please.
Thank you. The next question, la prochaine question est de Catherine Lévesque de la Presse canadienne. Please go ahead. La parole est à vous.
Oui, bonjour à vous tous. Mes questions seront pour le ministre Miller. Justement, je voulais poursuivre dans cette même veine. Je voulais vous entendre en français, en fait, sur ce projet de loi qui, on comprend, vous voulez co-développer avec les peuples autochtones. Je me demandais donc, qu'est-ce que vous espérez accomplir concrètement et comment est-ce que ça viendrait respecter le principe de Joyce et quand est-ce que vous espérez en fait présenter le projet de loi? Est-ce que vous avez une idée là déjà?
Pour être très clair et pour répondre à la question directement, j'ai aucun échéancier pour présenter un projet de loi. Ce que je sais, et je l'avais répondu à Brett, c'est qu'en entrant en fonction, c'était dans mon mandat, il y avait déjà un discours du trône qui annonçait ce projet. Ce que je vise, ce que nous visons tous, c'est la parité, l'égalité des peuples autochtones dans le traitement du système de santé. On sait très bien qu'on est très fiers de notre système de santé au Canada. C'est un système de santé de première classe, mais malheureusement, pour des raisons historiques de colonisation, du colonialisme, l'impact du racisme systémique dans le système de santé vis-à-vis des peuples autochtones rend les peuples autochtones des citoyens de deuxième et même de troisième classe dans le système de santé. C'est une juridiction qui est évidemment jalousement gardée par les provinces. Il y a eu toutes les tensions politiques qu'on connaît depuis belle lurette. Donc, c'est un champ de mine, on le sait très bien. Mais c'est en le sachant qu'on peut adresser le problème. On sait qu'on ne le fera pas ensemble en ce qui a trait au racisme systémique, un leadership qui doit s'exercer à tous les paliers de gouvernement. Et en ce qui a trait au rôle de devoir fiduciaire du gouvernement fédéral envers les peuples autochtones, c'est une autorité qui est bien enchâssée dans la Constitution et je ne suis pas constitutionnaliste, mais bien avant ça aussi. Donc, à la lumière des projets de loi qui ont été tissés d'une façon très différente des autres projets de loi par le passé, dont je nomme C-91, la loi sur les langues autochtones, C-92, la loi sur les services à l'enfance, qui faisait face à l'horreur, la tragédie des enlèvements des enfants autochtones. C'était un effort de réformer le système, de bâtir des lois en coopération, en partnership avec les peuples autochtones. on n'a pas atteint la perfection. Il ne faut pas se cacher le fait que ça a été très difficile. Ça a pris un engagement, une concertation, mais il y a eu des critiques. Et c'est en sachant cela, en rentrant en fonction, que je voulais prendre le plus de temps possible avec mon personnel de faire de la consultation. Et donc, les sommes qui ont été annoncées dans la mise à jour fiscale d'automne annonçaient 15,6 millions de dollars. Il y a eu l'urgence, évidemment, de cette pandémie de niveau mondial qu'on n'a pas vu depuis 100 ans, qui a fait en sorte que ce projet, et à la lumière de ce qu'on a tous vu vis-à-vis le traitement exécrable souffert par Joyce Echaquan, un traitement qui est normalisé par les peuples autochtones qui vivent au jour le jour, l'urgence de mettre en place et d'accélérer ce processus. Il va falloir, cela étant dit, continuer la consultation, le dialogue avec les partenaires, avec les peuples autochtones qui revendiquent ce droit, un droit à l'autodétermination sur leur propre mainmise sur leur système de santé, des systèmes qui ont été sous-financés par le passé. On le voit très bien dans le système bien. Ça, c'est une responsabilité fédérale. Et on parle beaucoup de responsabilité provinciale. On voit beaucoup, et surtout ce qui arrive au milieu urbain, au peuple autochtone, qui est inacceptable. Mais il y a beaucoup de travail à faire qui relève du fédéral aussi. Il ne faut pas se le cacher non plus. Donc, c'est tous ces éléments qui font en sorte qu'on va prendre le temps de le faire. L'introduction de la loi, la présentation de la loi, c'est pas pour demain parce qu'on va prendre le temps de bien faire nos affaires, mais on sait qu'il y a des urgences. En ce qui a trait, je sais que les gens vont poser la question, qu'est-ce qu'on va faire à la suite puis à la lumière des discussions qui se sont déroulées au cours des 2 dernières journées. Moi et nous, dans nos propres champs de compétences, on a le déploiement du vaccin de façon éthique et juste envers les peuples autochtones qui doit se faire de concert, main en main avec les provinces et les territoires. Et ça il va falloir faire nos preuves envers les peuples autochtones. Jusqu'à maintenant, c'est réussi, mais il reste beaucoup de vaccins à déployer, comme vous avez vu au courant des 2 dernières journées, 3 dernières journées en ce qui a trait aux vaccins qui rentrent dans le pays. Mais encore faut-il le faire, le déployer à la hauteur de notre système de santé qui préconise la justice, la parité envers tout le monde. Et dans le cas de gens qui sont, je sais que je réponds très longuement à votre question, mais qui sont vulnérabilisés et qui sont plus susceptibles à la COVID, dont les peuples autochtones, c'est quelque chose qui doit se faire en priorité aux peuples autochtones.
Catherine, avez-vous une question de suivi?
Oui, absolument. Merci pour la longue réponse. C'est ça, vous l'avez dit vous-même, là, vous aventurez un peu dans un champ de mine. C'est sûr qu'on parle des compétences des provinces en santé. Justement, lorsque vous en avez parlé dans les 2 derniers jours, comment est-ce que les provinces ont réagi justement à l'idée que le fédéral, disons, vienne empiéter un peu plus sur leurs compétences? Est-ce qu'il y a des provinces qui ont réagi plus fortement que d'autres?
C'est à voir. L'heure était vraiment pour les élus, puis surtout les élus provinciaux et fédéraux et territoriaux, d'être à l'écoute. On a pu prendre la parole en fin de journée aujourd'hui, mais l'heure était encore à l'écoute, d'écouter ceux qui vivent cette expérience. Alors, je ne pense pas que c'était la place pour qui que ce soit de faire des grands énoncés politiques. J'ai pu sentir une ouverture d'esprit. Je sais que vous voulez me parler du Québec. Le ministre Yann Lafrenière s'est présenté, a donné son engagement de combattre le racisme. Je lui crois évidemment sur parole. Je le crois de bonne foi, mais il y a beaucoup de travail à faire. Et ce que les peuples autochtones nous disent constamment, c'est qu'il va falloir faire nos preuves. Alors, il va falloir faire nos preuves. Le ministre, j'ai été touché par les interventions du ministre Dix de la Colombie-Britannique, qui nous a dit très clairement que les preuves doivent être faites au point où les Autochtones sont accueillis, en bon français, le point of care. Donc, là où les gens sont accueillis et ont leur première expérience avec le système de santé quand ils sont en détresse. Et ça, c'est du travail plutôt de longue haleine.
Merci, Catherine.
Catherine, je sais peut-être même la ministre Bennett ou la ministre Hajdu pourrait peut-être dégager des impressions des provinces, mais c'était mon impression quant à moi.
I think that's good.
Mute button.
I had it in French, but Joyce's principle, just to remind people, and it is what we believe, that Indigenous people have an equal right to the highest standard of physical and mental health, with a right to traditional medicines and the conservation of their vital medicinal plants, animals, and minerals. It says that governments must recognize Indigenous rights to autonomy and self-determination in matters of health and social services. So I think that's, in some ways, a little bit being able to assert their jurisdiction in the way that C92 does.
Merci, Catherine. Opérateur, prochaine question.
Thank you. The next question, la prochaine question est de Mike Lecouteur from Global News. Please go ahead. Your line is open.
Thanks for this. Minister Miller, I know a couple of other colleagues have sort of danced around it. I just wanted to ask you really pointedly. You said yesterday that Canadians expect concrete answers, stop calling things out. So from what happened over the last 2 days, what is actually going to turn into concrete measures to help Indigenous people trust the healthcare system again?
Yeah, and thanks, Mike. It's important. You know, it's if people had a solution tomorrow, it would be an entire misunderstanding of the scope of the problem. And clearly, what we heard today, and as I mentioned to Catherine Lévesque in French, this was time for us to continuing our listening to those that have experiences that I personally have never had at all with respect to the healthcare system, because I get the benefit of a first-class healthcare system. Indigenous people don't. It's often second or third. So we did make announcements with respect to supporting the community of Manawan in the sum of $2 million to work on Joyce's principle and concrete solutions that they would like to see. Mr. Hajdu announced another $4 million to support Indigenous organizations and physicians in a number of their initiatives and pushing forward the actions that they would like to take. For me, in my ministry, I announced, and I wouldn't say it was breaking news because we talked about it in 2 throne speeches, but the launch of an incredibly important piece of legislation that will take some time to put together in terms of distinctions-based healthcare legislation for Indigenous peoples, but that will take time. The immediate challenge and the immediate rollout of the vaccines in a way that reflects what we say the healthcare system should reflect is absolutely top of mind to me. So far, in terms of the prioritizations that have been made by the NAC, it's getting long in the day, Mike. NACI, the provinces have been pretty good in prioritizing Indigenous peoples, and we've seen that rollout into communities, sometimes with real logistical challenges. In the case of northern and remote communities, the objective, which is still on track, of getting both doses into arms by the end of March for 75% of the populations in the territories, who are exceedingly vulnerable, not only in their not only in the fragility of their healthcare system, but the ability in the conditions of a housing deficit and cramped housing conditions to have the virus spread like wildfire, with real mortal consequences. And this isn't imaginary data. We can see it, what's happening in the States, with numbers from 3.5 to 5 times the impact of COVID on Indigenous peoples, with a mortality rate that the CDC is quoting at 1.8 to 2 to Indigenous peoples, and even at younger ages. So we're worried about that, and Indigenous peoples even more so, as they're composing with odds that are far greater than non-Indigenous populations. Now, from their perspective, facing a 100-year, once in a 100-year epidemic, the proof is in the pudding, and getting those vaccines into arms in a culturally safe manner. So people talk about short-term deliverables. this will be a chance for Indigenous peoples to evaluate the words that we've said and judge us accordingly. I know from my experience of, even though I have never experienced the issues that have been discussed over the last 2 years, that that when Indigenous peoples have the assets and resources and the assistance of the federal government in a respectful way, the results are there to prove it throughout COVID. And I could get into a lot of the stuff that we've done during COVID, knowing that there is much more to do. But I say that because the issue of self-determination over healthcare is key, foremost as a matter of right, but also as a matter of positive medical outcomes to the communities that face lower socio-determinants of health in what we all believe and what I believe to be the best country in the world.
I'd just like to add that, through Patty's department in the Public Health Agency, that the National Collaborating Center on Indigenous Health is really going to be the repository for all of the wise practices in cultural safety, cultural humility. I think a lot of people really liked the video that they showed us today, both days during the break, but that was released last week on stigma and discrimination and what that means. And so I think that there is this ability for us to lift up what is happening across the country. Nobody has to start from scratch. And the kind of competencies that all healthcare institutions, all healthcare providers need to understand is something that we can support, but then it will be up to the individual institutions and healthcare providers and centers and hospitals to really put it in place.
And if I can,
follow-up. Oh, sorry.
Yeah, sorry for a follow-up. I was
Go
just
ahead.
going to say, picking up on what you were saying there, Minister Miller, about the rollout of the vaccine, how much pressure are you putting on yourself? And at the same time, how big of an issue is it to have a proper and a safe rollout of this vaccine to not only counter that history of mistrust in the healthcare system, but possibly take steps to repair that and maybe move on to the road of reconciliation with this moment in time and this vaccine rollout?
Well, Mike, I'm really cautious about drawing any great conclusions about how we've done things at this point. We're still in the middle of a pandemic, and I wake up every day, and I know it's the case for Patty and Carolyn, wondering how we can do things faster. The deployment of the vaccine is I think top of mind for every single cabinet minister, and in my portfolio and the one that touches Carolyn and Dan Vandel's on pretty much a daily basis, getting that into Indigenous communities presents a set of logistical challenges that aren't present in non-Indigenous communities or in a big urban center. I do worry about the Indigenous populations there, but that's a challenge in itself with provincial healthcare systems. We are, one of the key assets that we've brought to bear during this pandemic, which is the result of some novel thinking, is ensuring that the assets and the logistical force of the Canadian Armed Forces, where all the plans start to fall apart when COVID really gets into a community, well, the Armed Forces can step in and help, but that takes an immense amount of planning. My biggest hope is that we'll actually learn something about this coming out from the pandemic. Minister Hajdu and I spoke about this today. We really have to learn some lessons about how we've deployed our assets and how we've served Indigenous communities according to the oaths we all took when getting into office, but also as a matter of human nature. And that involves trusting voices on the ground when they say, "Hey, we've got a problem. You got to move." There's a lot of red tape that needs to get cleared between the time someone says, "Hey, we need some help. Our pandemic plan isn't working despite all our best efforts. Can you come in and help us?" And the time we deploy, for example, the armed forces, and time, if you wait 1 or 2 days, the case can go from 5 or 10 to 200 and 300, and whole communities shut down, which isn't surprising because you can shut down big cities, frankly, if COVID gets out of hand. So There are a number of lessons over trusting people that are telling you what's going on the ground, working hand in hand, constant communication with chiefs and council and health authorities, making sure the most up-to-date information is getting into communities. That's a huge challenge for us as we deploy the vaccine, working against legitimate fear of the healthcare system in terms of vaccines and deployment of the vaccines in a culturally safe fashion, leveraging assets, leveraging people, and the elders showing the way and using their languages to give people the full complement of information so they can take an informed choice as to whether to get the vaccine. So far, we've been really pleasantly surprised. We're playing with conservative estimates of doses, but I would say there's been about it's closing in on about 40,000 vaccine doses that have been administered in and around 100, closing in on 200 communities, with many clinics being planned over the next couple of weeks, and that's pretty impressive given the limited supply. Most of them are Moderna, but in some closer areas with ultra low freezing capacity, the Pfizer option is being deployed as well. But that's a whole logistical challenge that I think we wake up every day saying, hey, what's going on, and how can we help, and how can we get things out faster and quicker, and in a way that's respectful.
Thanks, Mike. Operator, next question.
Thank you. Merci. The next question, la prochaine question est de Mackenzie Gray from CTV. Please go ahead. Your line is open.
Hi there. My questions are for Minister Hajdu. Minister, with all the confusion today about 5 doses in a vial or 6 doses in a vial, has Pfizer given you any assurances that if Health Canada says, nope, we're sticking with 5 doses in a vial, that they will come through and give us 4 million doses? Or are we going to end up with only 3.5 million, which is what the provinces were told earlier today?
Oh, well, thanks, Mackenzie. As you know, sorry, I'm getting a bit of a reverb here. So, as you know, Mackenzie, the Major General Fortin gave this update earlier today. We are having conversations with the manufacturer, and this decision is still under review with Health Canada.
So you don't know from Pfizer whether or not, if Canada ends up saying we're sticking with 5 doses in a vial, what the delivery schedule is going to look like? Because it seems like Pfizer is going ahead with 6 doses, regardless of what Canada ends up saying.
I'm not going to speculate at this point, Mackenzie. The Health Canada regulators are doing their important work, and the conversations with Pfizer are ongoing.
Thanks, Mackenzie. Operator, next question, please.
Thank you. Merci. The next question, la prochaine question est de Joan Bryden from the Canadian Press. Please go ahead. Your line is open.
Hi, Ministers. I'm just wondering, you've all referred to what you've heard over the last 2 days and how moving it was. Tell us a little bit about the things that moved you the most.
Maybe I'll start, Joan, and I'll send it over to my colleagues. And to the technicians in the room, if you can stop the reverb, that would be much easier for my thinking process. One of the most moving pieces, I think, for me, and maybe it's because I've given birth to 2 children, but the repeated reference to the trauma that Indigenous women face in trying to give birth, well, first of all, not in many cases being able to give birth in community, having to give birth often far away from loved ones, family, disrupt any kind of cultural process that might go along with giving birth in that community, and then the fear and anxiety of obviously what will happen to them and their children, along with the combined anxiety around child apprehension. I think those stories, I don't think anyone can listen to those stories and not just have a great deal of grief for the women that go through this and continue to, by the way. Most women in Northern Ontario do have to fly into larger centers to give birth to their children, and it is divorced from community and often from ceremony that would go along with giving birth in a community setting. So that's, I think, one area that is very touching to me. And it's certainly not new to hear those stories, but I think every time I hear those stories, especially when people share their own personal experiences, it's very, very poignant. I think for me, the stories compound what I mentioned in my opening remarks, that this isn't, I should, listen, racism is horrible, but it's not an uncommon occurrence. It happens to Indigenous people, regardless of their own social location, regardless of their own particular status in their community or in the community in which they find themselves. This happens every day to Indigenous people in a million small and large ways. So much so that the Indigenous people that I worked with in community often sought alternatives to traditional care. So, for example, if there was an underground, person who had a little bit of nursing experience, they might seek care from someone that they trusted would treat them with kindness and with respect and with compassion, who maybe didn't have the skills to actually deal with that level of care over a medical system where they would and had experienced severe exclusion and violence in some cases. And so those kinds of stories that compound those histories, I think, are also very difficult to hear. And oftentimes when we're hearing from Indigenous practitioners, what we're hearing are the need to hide their indigeneity, if you will. And I think one of our speakers talked about that, the need to put on essentially a white mask to make it in a world where being Indigenous and Indigenous ways of knowing, Indigenous ways of medicine, Indigenous ways of healing are not only not taught, but they're not even really accepted. And so this need to sort of walk in this second land, if you will, and negate parts of them that are really integral to their own identity. Those are also very painful to hear.
I think as well that the death of Silatik Kudvik, who had to come out of Nunavut to give birth and then died of COVID, was very much part of what we heard yesterday from Pautudik, but what we heard at their annual general meeting. This has been really upsetting as the birthing center in Rankin has had to be closed. This is people want their children born in their communities and their elders able to die in their communities, and that we seem to be in the way of that, and in a sort of colonial way. I think I've had the privilege of meeting with the Indigenous physicians every Thursday night since March. I think that all of them have had such poignant personal stories that we heard in October. But, Dr. Lana Potts, for her to be advocating for her patients to actually describe what happened to her as a patient, but also what happened to her in medical school, that this is why it's so poignant and why people think, they've heard all these words before, nothing changes. And I think that these meetings, really, no one's saying that it doesn't exist anymore. Everybody knows it does exist, and they look at the outcomes and the suicide rates and the ability, for people to just, as we've said, not really want to go to hospital because they had such a terrible time last time, and then by the time they do access care, they're way sicker than they should have been. So I think that it is about raising the awareness and also understanding that from the colleges of physicians and surgeons to Accreditation Canada, what happens when something bad happens? Are there consequences? And I think that all of the accreditation bodies and colleges and are now really deciding they better look at this. In this is just not safe system for Indigenous people at the moment.
And I guess my view that I've been reflecting over the course of the two meetings is just, we're talking of the people that have been talking about their experiences, particularly in the medical professions, the doctors and nurses, highly trained individuals. They've had to rise up out of conditions that were unacceptable to become the cream of the crop. It takes pretty good grades to go to med school. I know Carolyn went. I probably didn't have much of a shot, but you know, we're talking about the cream of the crop of society. And when it talks about Indigenous peoples overcoming obstacles to get there, they are great. They are immense, and they face racism and systemic racism every step of the way. You know, someone like Donna May Kimilarjik was the first Indigenous cardiac surgeon and a doctor who is at the Cleveland Clinic. So, you know, one of the foremost institutions in the world still faces these things. And this was the lived experience of many of the doctors that were talking to us about a Medicare system that I feel is the best in the world. And those are the, you know, these are the lucky ones, educated, that have faced the challenges, that are the ones that have peers that are treating other people like garbage. And I took some time to think about why I was thinking about those that were really the exceptional ones that were being treated, and why I was reacting more strongly to those than everyone else initially. And then it brings it back to what someone like Joyce Echaquan faced, who didn't have familiarity with the medical system and is actually the patient and is at their most vulnerable and is being treated in a racist fashion, and is suffering the effects of systemic racism, reverts to her own language, which a lot of us do in our moments of vulnerability. You know, you think about, there was a story in the news 2 years ago about the transportation of children to the south, and I'm not pointing fingers. The health minister at the time in Quebec had said, and perhaps clumsily because he was expressing himself in not his language, but in English, about the adults that would have been let on board and no accompaniment. And he said something about substance abuse, and regretted it obviously and apologized, but he hasn't expressed himself. And he said this was not his language, and rightfully presented his apologies, and that, you know, I think that was fixed, and now there are people that accompany their children to the south. But for a lot of kids, that's their first interaction with the healthcare system, being vulnerable in their own language. And think about all those kids that were on the plane and had to go into a care system and be vulnerable and not be able to express themselves properly. So that's a real repercussion of those that don't have the benefits. I guess I was sort of drawing that parallel, saying there's a heck of a lot of work to do. We know it. And there's still mistakes being made. We know it. It's in the reports. It's my belief every province should probably turn out a report such as the one that Marilyn Pelafont did in BC, because they probably have substantially similar conclusions. But these stories are there. They're important, but they also do guide our reflection and how we move forward. I think the focus, because it was people that are working at the point of care for the course of the last two meetings, there's a lot structural that we need to do, obviously, but did focus on point of care, but it boils down to dignity, respect, and equal treatment.
Joan, did you have a follow-up?
No, that's good. Thank you.
Okay, thanks, Joan. And we have time for one more question, operator.
The next question, la prochaine question est de Olivia Stefanovic from CBC News. Please go ahead. La parole est à vous.
Hi, ministers. With the development of this new Indigenous health legislation, does this mean Métis will begin receiving federal health coverage and have their prescriptions covered, for example?
Hi, Olivia. I can't give you an answer right now. These are discussions that we will have to have. I'm familiar with a lot of the criticism of FNIB in particular by the Métis National Council, and so these are, you know, we need to be informed moving forward on what the Daniels case, the Supreme Court, which is a recent Supreme Court judgment, said, and the implications that it has. But those are discussions that we will need to have with the appropriate rights holder of the Métis. So I won't give you an answer on that.
Olivia, do you have a follow-up?
Yes. And with the creation of this legislation, does that mean that your department is moving towards dismantling the First Nations and Inuit Health Branch?
Well, if you recall the history of FNIB, it only recently moved over to Indigenous Services Canada, as it was housed in Health Canada. Prior to that, there's still work to do within our department to make it or to transform it into what Indigenous peoples expect of it. But I most certainly wouldn't at all signal a dismantlement of it.
Thank you. Thanks, Olivia. This ends today's press conference. Ceci met fin à la conférence de presse. Merci.
Thank you. Merci. The conference has now ended. La conférence est maintenant terminée.